All right.
So if I don't use this thing.
They will not be able to hear it, and I won't be able to record it.
Okay, well, I'll do it.
But it's kind of half of one and six of this. All right, and I think we've got that now at your starting point.
Okay. All right. Well, thank you for having me. I thought I would just go through an overview of a couple of common upper extremity conditions, and if you have questions along the way, feel free to interrupt me and you can get them answered. Do I need to?
Okay, I was recording for everybody else too, but if you want to try it without a microphone, we'll give it a try.
I'm certainly whatever you want to do. Can you hear me okay if I speak up a little? Is that okay? All right, we'll do it that way. So I thought I would just kind of introduce myself a little more. I'm the oldest of four. I was born and raised in Iowa and moved around Iowa quite a bit. My dad was a Methodist pastor, and so I like to say he couldn't hold a job, but really it was just the way the system worked. And so I did my medical training, or my undergrad training at Luther College, moved to Iowa City for med school, subsequently to St. Louis for residency for 6 years, and then fellowship in hand and upper extremity surgery at the University of Gainesville, Florida, and then found my way back to the Midwest to be closer to family. So that's been kind of my journey here over the last 15 years.
I know they can't hear you back there, so I'm going to just try this again.
Okay.
Sorry, I just know the person in the back can't hear because I was trying to listen.
Test.
Yeah, try it.
Okay.
We'll see what happens.
Okay. So then I've been at the. That's tough.
Well, let me turn this down. Because this is loud. You want me to turn it up? No, I think that I turned it down. Try to get.
I've been at the orthopedic fracture clinic now for 3 years. Wife Jessica, I have two kids, Lachlan and Isla. Lachlan's 6, Isla's 4. So I figured we start with rotator cuff tears. Again, feel free to stop me. It's really tough.
Yeah.
I don't know if I can do this.
Okay, we're gonna have. I apologize.
Maybe how about this? Can you folks sit up here? Would that be too much to ask?
Okay, let's try to see if we can get this testing. Okay, you know what? You're right. You might have to go out there.
Or what if?
Can you do it? If I
Yeah.
have a microphone?
Right, I can.
Or speak up. I'm sorry. I apologize today. We'll figure out what's going on.
Okay, so first, just a little basics on the shoulder anatomy. It's basically a ball and socket joint. The acromion is the cup or the ball or the socket, which is very shallow, and then the humeral head interfaces with that. The rotator cuff muscles are on the outside. There's one in front, one up top, and 2 behind, and those muscles help give the joint stability so that you can move your arm and the ball won't dislocate. And of course, they each have Latin names, which I won't bother you with. Sometimes those muscles can become torn, and it's generally a spectrum of injury. It usually starts with some inflammation that can progress to a partial thickness tear, and then that can progress to a full thickness tear. This lower image is an MRI that depicts that. You can see on the outside there that on this view, white is fluid. And when you have fluid that traverses the whole rotator cuff, that's considered a rotator cuff tear. The top image is what we see in the scope. That's what a tear looks like visually. So this is a very common problem. By the age of 60, over 50% of people have a rotator cuff tear. Not everyone has pain though. And so most tears are degenerative, meaning they happen over time. Sometimes they happen from a fall, an identifiable trauma that causes the tissue to rupture. And larger tears create a larger loss of shoulder function. What we know about these is that they don't heal on their own. They do tend to get larger over time if you don't fix them. And some people with rotator cuff tears don't have any pain at all, but many patients eventually will have a problem. And so that's where we get involved. But typically the first approach here is non-operative treatment. And so that involves taking anti-inflammatory medicines, that involves physical therapy. Sometimes steroid injections can provide relief. You can modify your activities to avoid pain. And in general, 60 to 70% of people will improve with these measures. But like I said, the rotator cuff itself will not heal. We can make it less painful, however. If those things don't work, then sometimes we need to make a decision to proceed with surgery. And that depends on the patient's goals. Generally, we're trying to maximize function. And so this is typically done arthroscopically.
Sorry.
This is typically done arthroscopically. It's done through small incisions on the outside of the shoulder, and it's done at an outpatient surgery center. We can do it at the hospital, but the patient generally comes and goes the same day. It's pretty well tolerated, and there's a 90 to 95% chance of improvement for small and medium-sized tears. Larger tears are less predictable. Also, patients who are smokers, patients who have diabetes, patients who have large or massive tears are less predictable. Also, recurrent tears, patients that have had multiple steroid injections are also at risk for not healing the repair. So this is generally how it's done. Again, small incisions. We put water into the shoulder with the scope. And these are some diagrams for how the anchors are put in. The anchors are made of plastic generally. They're connected to suture, and that suture comes around the rotator cuff tissue and pulls it down to the footprint to allow it to heal to the bone. Here's an example of how that's done. Usually it's two to four anchors are used generally. And then afterwards, patient goes to therapy. You're usually in a sling or a shoulder immobilizer. You do some exercises. Phase 2 starts at the 6-week mark with stretching. You can move the shoulder, but you're not really using it for resistance types of activities, no lifting until the 3rd phase. And it's very common for strength to be lagging up until about 6 months. You can continue to see strength gains within that time period. So the next topic I was going to mention is shoulder arthritis, and that is linked to rotator cuff problems. I'll explain how in just a minute here. So the deltoid is a muscle on the outside of the shoulder that acts to help extend the arm. However, in order for it to work effectively, the shoulder has to pivot. And as I mentioned earlier, the rotator cuff helps keep that ball centered on the socket. As you see here, the deltoid on the outside pulling the arm up. And so if that rotator cuff is not working correctly, then there's slide or slack at the joint. And the humeral head will start to slide around and become unstable. And what that can do is create arthritis because there's abnormal cartilage contact at the joint. And that can be an independent source of pain. And here you can see what happens. The head will slide up into that space where the rotator cuff is due to the tear. And so the cartilage breaks down. The joint surface is no longer smooth. There's loss of joint space. the bone erodes and you get bone spurs as a result. This creates pain and swelling, progresses over time. There's loss of motion, and then the muscles also lose their strength because they aren't being used normally. It's very common to have crepitus, which is clicking or popping sensations when the patient moves the shoulder. And so again, we use conservative measures first. So that's anti-inflammatory medicines, steroid injections, therapy, and modification of activities before we discuss surgery. And so the decision to proceed with surgery is based on lifestyle. If the pain is significantly interfering with activities, if there's loss of independence with doing daily activities like grooming, bathing, dressing, if it interferes with work, those are all reasons to proceed. And so this is there are two types of operations we can do. The first operation is a total shoulder replacement, where the ball is replaced for a ball, the socket's replaced with a socket. We can do that when the rotator cuff is intact. If the rotator cuff isn't intact, we need to link the humerus to the glenoid. And that's done by reversing the components, by putting a ball on the shoulder blade and a socket on the humerus. And I like to use the trailer hitch analogy. The arm is then linked to the shoulder blade, and the deltoid muscle on the outside can help the patient position their arm. So this is done through an incision in the front of the arm like this. First, we have to remove one of the muscles in the front, and that exposes the arthritis. We remove the arthritis from the humeral head and place a socket into the humerus. This would be a reverse shoulder replacement. And then on the shoulder blade side, we put a ball that's linked to a base plate and some screws that goes into the bone. And then this is sort of an X-ray depiction of what that might look like once we're done. I do this operation a little bit differently from other folks. I'll get a preoperative CT scan, which helps look at the bony deformity. And then that allows me to use a computer navigation to place the components where I template it, which I do before the operation. So it allows us to be more accurate than we previously were. If you think about drilling into the shoulder blade, it's like drilling into the side of a dinner plate. Not quite that narrow, but there's not a lot of room for error. And before we had this technology, we were doing a lot of guessing. This technology has really removed the guessing from that. So the post-operative protocol is very similar for the first 6 weeks. Patients in an immobilizer, they're doing pendulum exercises, and then 6 weeks of range of motion, either with pulleys over the door, as you see here, or exercises with a cane. And then the third phase is geared towards strengthening. And then the fourth phase is advanced strengthening with the resumption of activities, hopefully by 6 months. Again, you can continue to see strength gains out to a year after surgery. Very predictable relief of pain and improvement in function. And the ultimate goal is a return of independence and improvement of the patient's lifestyle. So then I thought we'd move down the arm a little bit to the thumb and talk about the base of the thumb. That's called the basal joint, or the first CMC joint, a very common place of arthritis in the hand. The thumb joint has a large freedom of motion and allows for pinching and gripping activities. It's prone to arthritis because when you pinch with 1 pound of force between the thumb and index, the base of the thumb sees about 10 to 12 pounds, depending which article you read. But basically that is responsible for the fact that it's a common place for arthritis in the hand. And so what will happen is that the base of the thumb will start to slip out of place slightly as the ligaments are stretched. And that creates abnormal cartilage contact and the development of arthritis. And so this is an X-ray. On the left, you see a normal appearing thumb. On the right, you see a thumb with arthritis. And you can see how that bone is slipped out of place slightly. And there are large bone spurs and narrowing of the joint space, which is very common in this condition. We grade it in 4 stages. And here you can see an example of each of those 4 stages. Aching pain is very common. Activities such as grasping a cup or turning a key. It's very common to have cracking or popping in the joint. And you have this swelling. The swelling is due to, not only the inflammation from the arthritis, but also the fact that that bone has slipped out of place slightly. And a lot of times there is a side-to-side difference between the symptomatic hand. So the initial treatment is always non-operative, generally geared towards using a splint. There are oral and topical medicines that can be helpful. Steroid injections are very helpful. They can give 3 to 6 months worth of relief. Therapy can also be helpful to strengthen the hand, to improve performance of daily activities. And then when those things fail, we start talking about surgery. Here you see an example of some of the splints that can be used for this. There are custom splints that can also be made that can be helpful. Aleve, Advil, Motrin are the typical anti-inflammatory medicines we use. And then, as I mentioned, therapy to strengthen the surrounding muscles to improve daily tasks. This is how a steroid injection is done into the base of the joint. I prefer to use an ultrasound machine to guide the placement of the needle because it's a small joint, and I prefer to be as accurate as possible with the injection. And so then surgery is the next step if those things don't work. One option is to do what's called a denervation procedure. This is for people with early stage arthritis. The goal here is to remove the pain fibers that go to the joint. And so I will generally first scope the joint. You can see an example of that. And then sometimes it's necessary to make a little larger incision to remove those nerves. So that doesn't really affect the structural integrity of the joint. It's mainly a pain relieving operation on the nerves. Again, for early stage disease. Then when symptoms are more severe, mid and late stage arthritis, we do an operation called a suspensionplasty. That involves removing the trapezium, which is the arthritic bone at the base of the thumb. And then I transfer a portion of a tendon to support the joint, and I back it up with another device called a mini tightrope. That device involves a couple of buttons the size of a grain of rice, and they're connected by some suture that suspend the thumb bone over that space. And so that's why it's called a suspensionplasty. You can see an X-ray and a depiction of what that looks like. So this is done in a surgery center. It's outpatient, so you come and go the same day. The patient wears a splint for 10 to 14 days after surgery, and then the sutures are removed, and the patient starts moving the thumb with therapy at the 10-day mark. Generally, the motion has returned by 6 weeks. There may still be some weakness with pinch and grip strength. That generally comes back by 3 months. And the operation generally has a very high success rate. Good. So that was kind of a whirlwind tour of upper extremity, some common upper extremity conditions. Obviously, there are many more that we could spend all day talking about, and happy to do that maybe at another date if you like. But any questions about that? Yeah. It's called a mini tightrope, like an acrobat. Yeah, and the idea is it's it's a suture that's suspended on either side by two little buttons. The buttons are on the bone surface. And the idea is that it's suspending the metacarpal at the base of the thumb, suspending it over the space left by the removal of the arthritic bone, the trapezium. So what that does is it allows the thumb to still move freely, and the arthritis has been removed because the bone's gone. So yeah, very, very predictable outcome. Yeah. Of 60, yeah. Yeah, generally it happens because the roof of the shoulder is the acromion. And as you're moving your arm, the rotator cuff can become pinched between the humeral head, the ball, and the acromion. And so when you're up doing these things, it's sort of like wearing a hole in your sock. Over time, the sock will thin, and then eventually you get a hole in your sock, but you don't always notice that you have the hole. You know, and the same thing with the rotator cuff. Not everyone has pain. You may have a partial thickness tear and never know it. You could have a full thickness tear and not know it. There are just certain people, and there's research going into figuring out who becomes symptomatic, who doesn't. It can, yeah, and because sometimes what will happen is the bones don't heal quite right, so they can contribute to increasing pressure on the rotator cuff if they're healed in a little bit altered position, which is common because those bony fragments are connected to the tendon, which is then connected to the muscle. The muscle is pulling on those bony fragments. So unless they have surgery to put it in the right place, yeah, it certainly can. Yeah.
Is it possible at all to have a rotator cuff problem on both sides at the same time?
Yes. Certainly is. Yeah. And another thing that can predispose you to having a rotator cuff problem is the bony morphology of the shoulder. In some people, the acromion overhangs the rotator cuff farther than others, and you can measure an angle between the socket and the edge of the acromion. And so there's some thought that may be a predisposing factor. It may explain why some people have it on both sides.
Like on the board with your grandchildren. I feel like maybe on the board with your grandchildren with the weight of your body on your elbows to play on the floor. About that.
It could.
Possibility.
Yes.
Bad practice, John. I'm not playing with grandkids.
Yeah.
Do you find you're seeing illnesses in younger people now with sports and stuff more, or with the effect of being on phones more and that kind of stuff?
I would say that younger people tend to have different shoulder problems. So in the younger athlete, for example, it tends to be the labrum, which is the lining of the shoulder joint that's more affected. In sports injuries, you're more prone to dislocating shoulder where they come out of socket. And that doesn't affect the rotator cuff, it's a little different problem. So generally don't see rotator cuff tears in the younger athlete as much as in people over history. Yeah.
When it's the natural, like just progression over time, do you see it as typically like if you're right-handed, it's going to be your right hand, right thumb, or your right shoulder, or is it pretty all over the place?
You know, you would think, but I can't tell you how many times people say, they come in, they're right-handed, but it's the left thumb that hurts, and they ask me back, why is it? And so I don't know that I can say that for sure, because I've got seen plenty of examples where that's not the case. So yeah, it's one of those things that doesn't always line up the way you think. One more question. Yeah.
Andrew, is arthritis symptom that we're all going to eventually face as we get older?
Well, I would say no. It's not just
mechanical wear and tear that causes arthritis. There are definitely biological factors. I've seen plenty of 90, 95-year-old folks that have pristine looking shoulders. And so there's more to it than just that. And that's an area of active research. Once you get that figured out, someone's, retire early. But yeah, we're not quite there yet. But I can tell you, it's not it's not like thinning hair and losing teeth and whatever else. Yeah, there's more to it. Yeah.
Is shoulder surgery more painful than knee or hip replacement surgery?
I would say if I had to grade them, least painful to most pain, from what I see, I would say hip is probably the least painful, followed by shoulder, followed by knee, the most painful. But we've made some advancements that make it less of an issue, such as doing nerve catheters. So for all my shoulder replacements and my rotator cuff repairs, we will do either a one-shot block or a catheter that gives numbing medicine in the shoulder. And that can give 2 to 3 days worth of pain and really decrease the amount of narcotics the patient needs to take after surgery. So yeah, and we do similar things, with epidurals for the lower extremity to make it easier. Yeah.
You hear a lot about the rotator cuff. And rotator cuff, is that group of muscles or specific muscle?
It's 4 muscles. So in the front, there's the subscapularis, in the top, the supraspinatus, and then in the back, there's teres minor and infraspinatus. And so it's 4 muscles that come together in a hood that come around the humeral head. I would say the subscapularis and the supraspinatus, the front and top, are the more commonly affected of the 4.
Well, we're at 102, so I want a nice round of applause for you. PowerPoint, if you want to just pull it out, that'd be great. Yeah, that should be fine. I don't think it'll do any damage to it, so thank you.
All right,
And I apologize for that. I know it was
well,
freakish.
that was the
You folks
struggle.
couldn't necessarily hear it, but to hear it just a half a step behind what you're saying, it was rather disorienting, actually. So thank you very much for coming today, Andrew. We'll get you a better experience next time. No problem.
Happy to do it.
All right, thank you. And just as a reminder, for next week, I see we've got John Harrington, who is the coach of the MSU women's hockey team, and also a member of the Team USA in 1980. So I'm sure that will be a wonderful presentation that he will be giving. I'm going to take this off. I'm going to stop recording.